Okay, great. Looks like we have a lot of people joining, so we'll go ahead and get started. I'm Dr. Valerie Flores, and I have with me here Dr. Brems, who's one of our urologists that we work with. And today we're really looking forward to speaking with everyone about what we like to call It Takes Two. So, taking the perspective of both male and female related factors and how they contribute to infertility or the fertility journey. And then also just letting our participants know that for those of you who are joining live, you do have the opportunity to have a free consultation with myself at San Diego Fertility Center and a free preconception consultation with Dr. Brems. And so with that, let me go ahead and share my screen. Okay. So again, the title for this presentation or webinar is It Takes Two, Understanding Male and Female Infertility Evaluation. I am Dr. Valerie Flores. I am a double board certified reproductive endocrinologist and infertility specialist. As I'm sure you heard us chatting just a second ago, I completed my undergraduate training at the University of Southern California, medical school and fellowship at the Yale School of Medicine, and my residency at Brown University Women and Infants Hospital. And Dr. Brems is also a board certified urologist. He completed his undergraduate training at the University of Notre Dame, medical school at Georgetown University, as well as his residency as well, and his fellowship at the University of North Carolina. And how we are planning to have this webinar is first I'm going to go through the female evaluation with the perspective of fertility as well as infertility. And then I'll pass it over to Dr. Brems, who will be speaking about male-related factors. And then after that, we'll open it up to discussion. We're really excited to take questions. And we also have a few questions that people have put in even before the webinar, so we're excited for this. Just to tell you a little bit about San Diego Fertility Center, we were established in 1989. We are very fortunate to be leaders in fertility treatment, including third-party care. And in 2024, we were actually named by Newsweek as the top fertility clinic in California. So, where to begin? So, in order for pregnancy to happen, we do need the ovary to be able to release an egg each month. And we ultimately need sperm to be able to reach the egg in the fallopian tube. So, fertilization must happen, then the fertilized egg must divide and ultimately become an embryo. And that embryo, in order for it to attach in the endometrium, needs to have a receptive endometrium. And so, what happens when pregnancy doesn't happen, or what happens when we're looking at potentially completing an evaluation for those who are looking to start their family? So I just wanted to go through a little bit of how we define infertility and then also looking at why we define it the way we do. So infertility is defined as a year of unprotected intercourse or a year of trying for individuals, particularly women who are less than 35 years old. The reason why we define it this way is because most couples, around 85%, would be pregnant within a year of trying. This changes a little bit when women become over the age of 35. We actually define infertility as 6 months of unprotected intercourse. And that's because one of the big changes that happens for women is that the number of eggs start to decline, particularly in our mid-30s, and the quality of our eggs start to decline. And so quality is really referring to the ability of the egg to divide properly and have the right set of chromosomes. And then for individuals who are in their 40s, we usually recommend a sooner evaluation, even if individuals have just started trying. And again, the reason why is because pregnancy rates per cycle, even in the absence of infertility, do decline with age. Peak fertility is really in our 20s, where we have a 20 to 25% likelihood of conceiving. By the time we're in our mid-30s, this does drop to 15 to 20%. By the time we're in our 40s, this drops to 5%. And by the time we're in our mid-40s, this unfortunately drops to 1%. I don't go through this to, make it seem like no one can get pregnant. The whole point of this is for educating and empowering our patients, and really also to recognize that infertility is much more common than we realize. 2 years ago, we said it affected 1 in 8 individuals. Now we know it affects 1 in 6 individuals, so you are not alone. And the purpose of Dr. Brems and I being here today is really to educate our patients and empower you so that as you're starting to think about building your family, you know what resources are available and also what testing options and fertility treatments we have. There are some situations, of course, where we do recommend seeking an earlier evaluation. I know Dr. Brems is going to focus on the male factors, but from a female perspective, individuals who have a history of irregular periods, because of course we want to evaluate for something called polycystic ovarian syndrome, individuals who have known or suspected blockage of their fallopian tubes, those with endometriosis, anyone who has a history of difficulty with intercourse, and then again, of course, if there are some male-related factors, which I'll let Dr. Brems talk about a little bit later. So what exactly does the fertility evaluation entail? From the female perspective, one is looking at egg quantity and egg quality, so looking at the egg reserve, also looking at the uterus and the fallopian tubes, and then from the male perspective, looking at the sperm. So what is involved in ovarian reserve testing? It does start off with some blood work. The main one is anti-Mullerian hormone, which is a hormone that's made by the eggs in the ovaries. It's a good indicator, not exactly of how many eggs a given woman has, but really looking at for a given woman's age, is it a good number or a low number? Anything over 1 is considered normal. We also look at a few hormonal tests, FSH and estradiol. FSH stands for follicle stimulating hormone. That's the hormone that is coming from the brain that is normally telling the ovary it's time to make an egg each month. And estrogen comes from the growing egg. It's the one time for these two particular tests that we actually like to see low values. So typically we like to see the FSH as less than 10, and this is checking it at the beginning of the menstrual cycle. And the estradiol should be less than 60. This is an indicator that the brain and the ovary are communicating well with each other to have proper egg development and ovulation each month. We also recommend a pelvic ultrasound. This is both to look at the uterus and also look at the cohort of eggs in a given ovary. So we don't actually see the eggs because they're microscopic, but we do see the fluid surrounding the egg, which we call a follicle. And if you look with the arrow here, this little black filled sac, that's a follicle. And within each follicle, there should be an egg. So we count these and we call that number the cohort for a month, and it should be similar from month to month. And then in terms of what else we use the ultrasound for, we're also looking at the uterus itself. So looking here, this is an image of the uterus, the top of the uterus here, going towards the cervix, and then this is the lining of the uterus. Particularly, we're looking for anything that is in the uterus that perhaps shouldn't be there. So any type of overgrowth in the lining, which could be from something known as an endometrial polyp or a fibroid. And then to better assess if we do think that there may be something in the uterus that shouldn't normally be there, we can do a saline ultrasound where we put some water or saline into the endometrial cavity, at the same time complete an ultrasound and look to see if there's anything abnormal in the uterine cavity, all of which is treatable, by the way. So we would talk about this in more detail if we did find something there. The last thing to look at from a female perspective is the fallopian tubes. And so one of the ways to do this is with a hysterosalpingogram. Very fancy term for a procedure where we have a water-based dye that goes into the uterus and ultimately through the fallopian tubes. This is usually done in a radiology department, and we're ultimately able to see whether or not that dye passes through the tubes. So here, this is a view of the pelvic brim, and then here we have the dye entering the uterus, and then you see it going through the fallopian tubes on either side. The point of all of that testing is to ultimately determine what the reason for infertility is. And so infertility can be the result of ovulatory dysfunction, so individuals who may not have a period every month, who may not be ovulating every month. It can be due to tubal factors or uterine factors. That's where the ultrasound and the hysterosalpingogram come into play. It can also be something called unexplained, which is a term that we're actually working on changing because many times you're coming to see Dr. Brems or myself for a diagnosis, and when we hear the word unexplained, it makes it seem like we don't know what the diagnosis is. But really what unexplained means is that it's in individuals where we do see eggs, we see that the reproductive tract for both men and women is functioning appropriately, there is sperm, but for some reason the egg and the sperm are having trouble meeting. And we would talk about different treatment options for those particular situations as well. And then of course, male-related factor, which we'll go into a little bit more detail later. But in terms of once we have that diagnosis, that's when we start discussing in a little more detail the different treatment options that are available. So, one can be ovulation stimulation or ovulation induction with or without an intrauterine insemination. Typically, this is done with oral medications, and how these medications work is essentially by tricking the brain into thinking that estrogen levels are low. And in doing that, it gets the brain to essentially work a little bit harder to tell the ovary it's time to make an egg each month. And this can be used for individuals who either have regular cycles, so for unexplained infertility, or even individuals with irregular cycles to get ovulation to occur regularly. And then typically we add on something known as a trigger medication. This is really just helping to ensure that ovulation definitely happens and it happens in a predictable way as well. The intrauterine insemination is a process by which the sperm can then be washed and concentrated, and then the sperm sample is placed directly into the uterus. And again, depending on the infertility diagnosis, this may or may not be something that's recommended in addition to the oral medication for ovulation stimulation. Who's a good candidate for this type of treatment? So individuals with unexplained infertility, those, as I mentioned, with irregular menstrual cycles, and as Dr. Brems will talk about in a little more detail, those men who may have a low sperm count or a low motility. And then the requirements, of course, are patent fallopian tubes, and then having a certain number of total motile sperm to help increase the likelihood that pregnancy will occur, that fertilization, ultimately pregnancy will occur. In terms of the different treatment options and how long we recommend doing something like ovulation stimulation with intrauterine insemination, we typically don't recommend going beyond 4 cycles. And that's because most studies have shown that the likelihood of pregnancy does increase up to and including the 4th cycle, but unfortunately doesn't actually increase much more beyond that. And so typically we recommend around 4 cycles. Of course, every couple is different, and so based off of your particular diagnosis, we will focus as well on personalized care. So this may be a little bit different depending on your particular situation. The other treatment that we talk about, if maybe ovulation stimulation IUI is not the best route, or if maybe that treatment has already been completed and unfortunately pregnancy hasn't happened, is in vitro fertilization. And so this is a process by which women take injectable hormones of FSH and LH, so the same hormones that women typically already have from the brain, but more synthetic versions so we can give higher doses to help ensure that we get a good number of eggs growing and ultimately retrieved. And we retrieve these eggs immediately before ovulation occurs. Anesthesia is used and everything is done vaginally. So there are no incisions on the abdomen. But the reason why we still give anesthesia is because there's a little needle that we do have to pass through the vagina into the ovary to suction out the eggs. And so we don't want patients to feel uncomfortable or be awake with that. And so that's why the anesthesia is provided. And thankfully, it's a very quick procedure. It's around 15 to 30 minutes. This is just kind of outlining in general that process. So the ovarian stimulation part is done with injectable hormones, all subcutaneous injections. Ultimately, an egg retrieval is undergone, which is a vaginal procedure, and with that small needle, we're suctioning out the eggs from the ovaries. We then create embryos in our embryology lab. So we have a sperm sample, the eggs are inseminated with sperm, and we watch these fertilized eggs develop into embryos. And then ultimately, we transfer the embryo into the uterus, and we define success not just by pregnancy, but that you have your little one to go home with as well. So this is just the process by which we inseminate the sperm with the eggs. So sperm is provided and or thawed if it's a frozen sample the same day that the eggs are retrieved, and one sperm is manually inserted into one egg or each egg. So this is called intracytoplasmic sperm injection. And then again, we watch these fertilized eggs grow in the laboratory. It starts off, day 1 is fertilization. Then we start to see cell division of the fertilized egg, ultimately culminating in a blastocyst or the embryo. And at this point, we can also perform a biopsy of the embryo to have chromosomal or genetic testing performed on the embryos. And then at the end of this procedure is the embryo transfer. Anesthesia actually is not needed because this is done under direct visualization. So it's actually a pretty cool thing to watch, both for the patients and for us as the providers. Ultimately, what happens is we get a view of the uterus with an abdominal ultrasound. Oops, sorry. And then we have the embryo in a small catheter, and then we place that directly into the uterus. And then 10 days later is a pregnancy test. I did want to talk a little bit more about pre-implantation genetic testing for those undergoing IVF. So this is a way that we are able to determine the number of chromosomes in an embryo. So essentially determining if it has the correct set of 46, 46XY for male, 46XX for female. It's particularly helpful for those who are over the age of 37 because again, one of the big hits that women get as we get to be in our late 30s, early 40s is that the quality of our eggs declines. And again, quality is really referring to the ability of the egg to divide properly, to have the right set of chromosomes. So this is a way to know ahead of time whether or not a given embryo is chromosomally normal. And then on top of that, we're actually also now able to detect single gene disorders. So if we have a couple who has a known history of a genetic condition, we can usually develop a probe that's able to then detect for that genetic condition as well. And then the last thing I wanted to talk a little bit about is fertility preservation. So some people are not actively trying to become pregnant, but knowing that egg quality and quantity decline over time, this is a way to essentially stop the clock. So it's a way to, again, do essentially that first half of IVF. So stimulation medications to get the eggs to grow. We retrieve those eggs and then ultimately freeze them via a process known as vitrification for potential future use. So this is really exciting because it's not experimental. It hasn't been for a while, but initially when we used to talk about this, it was considered an experimental procedure, and now it's not. There are many children who are born via egg freezing now, and also many women who are undergoing egg freezing. And so it really provides an opportunity for future fertility because the eggs are always of the age at which you froze them. So that's pretty exciting. With that, I'll stop sharing my screen, and that way, Dr. Brams, I'll let you share your slides.
All right, let's see here. Screen 3. Okay, and then you can see the PowerPoint now, okay?
No, I don't think you're sharing it yet.
No, oh, hold on one sec. Oh, hold on. Share,
There you go.
and
And then I
then
almost see your slides.
how about now?
I see your desktop.
She's my
There we
desktop.
go. Now I see your slides.
Okay, just making sure. Different screens, I have to make sure I went to the right one.
Yeah, no, no problem. But I could definitely see your slides.
Okay, very good. Yeah, so I will talk a little bit about the male side of the equation. We went through this before. I don't need to list off my schooling again. But as was mentioned, for a long time in the infertility world, a lot of the focus was placed on the female side of things and looking at, what causes there could be over there for infertility. But now we kind of know that actually in about half of the time for couples experiencing infertility, it can be the sperm. So roughly approximately 1/3 of the time, it can be female related. 1/3 of the time, it can be male related. And about 1/3 time, both partners can be involved. So it does take two to make this work. Just wanted to kind of quickly talk about some of the things that have been in headlines about the decline of sperm, the sperm apocalypse. I actually Googled spermageddon one time. We found some funny memes if anybody wants to do something like that. But there's talk about some of the decline in sperm throughout the world. I just want to mention that some of these studies, the quality of them is up. There is some debate about this, so should not be taken as gospel, but there have been some studies that show that there may be a decline in sperm counts and quality throughout the world. And so we asked ourselves, why might this be happening? So things like environmental exposures has been one proposed possible cause. Microplastics is a very hot topic right now in the news, and there have been some studies saying that some of these microplastic particles have been found in the testes. Now, to what degree does this make a difference clinically? Those kind of questions remain to be answered. And further, what can we do about it? But potentially there are some environmental exposures. Another common one that we might see is actually wildfire smoke. I know there's active research being done at the University of Washington right now into the impact of this. Nobody thinks that wildfire smoke is good for their health. To what degree it hurts fertility kind of remains to be seen. Also, just as a population, we do tend to be a little bit less healthy than we were a few decades ago. Everybody knows that the rates of obesity and things like diabetes and metabolic syndrome are kind of on the rise, and there have been some associations and studies linking those things and associating them with decline in reproductive health as well. And then something called the relaxed reproductive selection hypothesis, basically meaning saying that medicine is good now to allow people to survive and reproduce, whereas maybe they wouldn't have not have been able to before modern medicine. But kind of the answer is we don't really know why this is going on. There are limitations to those studies to suggest that they are fact. And then the other thing to mention is that even if semen parameters have been declining, that does not necessarily equate to a decline in fertility. So what can be done? And I know we talked earlier about how fertility is defined and when should somebody get tested. I will say on the male side, getting a semen analysis is really kind of the core of what we do, and it's a pretty simple and easy thing to do. So the threshold for guys to do that, I think, is a little bit lower than maybe going through all the testing that's required on the female side. And how does that get done? Well, a lot of guys say that it can be awkward. However, when you go to a fertility clinic, it is all that we do, right? It's not, I shouldn't say all, but it's a very, very common thing. It's something that the clinics do all the time. But a lot of guys do express some hesitation about that, which may lead to a delay in them getting tested. There are some at-home semen analysis testing kits, and the progress that's been made in those is actually quite impressive. And they're not bad as an initial screening test. I'm not talking about the ones that you might find on the shelf at CVS or at Target. I'm talking more about some of the more verified ones that we can order. But that is another not a bad way to get a screening test. But truthfully, the best way is to do one at a clinic like San Diego Fertility Center. And so then what if you do that and the tests come back abnormal? Well, that's where I come into play. So I'm a reproductive urologist, and so I do these kinds of things, all the time. And so you can make an appointment. We can talk about things that we can do to potentially help that. A lot of guys don't realize that many causes of male infertility are treatable. There's a lot of things that we can do, lifestyle changes we can make, and I'm going to go through all those in more detail in just a minute here. The other thing to mention is that a semen analysis, it's coming out now that this is actually a biomarker for the general men's health. I can't tell you how many patients I've seen where I'm the first doctor that a guy has seen since they left their pediatrician's office as a teenager. And it's so a lot of times people might not realize some of these things that they're doing can have an impact on their health. So I mentioned that a semen analysis is kind of the core of what male fertility is all about. It's like that's our big take home. So when you look at a semen analysis, I tell people there's three big things that I care about. Those three big things are the top three things you see here: the volume, concentration, and motility. So volume refers to how much semen volume there is. The concentration is how many sperm there are in terms of million per milliliter is what we're looking for. And then motility, how many of those sperm are moving. Not all the sperm are moving in a sample. Our lower cutoff for what's normal is about 40% or so. So those are the big three. When you combine them together, it gives you something called the total motile count, or how many moving sperm are in that semen sample. And that does correlate pretty strongly with fertility. Morphology, I view as kind of a secondary criteria. There's a rare condition where morphology is extremely impactful, but for most patients, it's less impactful than the other big three that I talked about. I also should mention that a semen analysis reflects sperm production over the past 3 months. So that's why I kind of encourage guys, if they want to be seen, go get that semen analysis done, because any changes that we're going to make, either in your lifestyle, medication, surgery, what be it, we're going to have to wait to see 3 months to determine the extent to which those changes might help. Conversely, negative effects can last for 3 months. So COVID infections, the flu, sicknesses, illnesses like that, they can be the negative impact those things can be reflected in the semen analysis for 3 months, sometimes even longer, depending on the severity of it. So let's say you want to get an evaluation, you want to come see me. So what do we do? So the first thing that we're always going to do is just do a medical history. We're going to go through, medical problems, medications, supplements, fertility history, previous surgeries. All of those things are very important in determining potential causes. We also talk a lot about the lifestyle things, which I'll get to in just a slide or two here. Physical exam. A lot of guys are nervous for their physical exam, but what does that entail? The most important parts is checking the testicular size, making sure there's no lumps or bumps. Rarely we can find testis cancer or testis masses on an exam, and that can be a cause for infertility. Don't want to scare anybody, those aren't common, but it is worth getting checked out. The other things that we check for are something called a varicocele, which are dilated veins that are within the scrotum around the testicle, and it has a warming effect, which essentially impairs testicular function and can lead to fertility problems. So that's something we determine on physical exam. In addition to that, we want to check the presence of what's called the vas deferens, which is the tube that transports the sperm from the testes to the ejaculate. So some guys can be missing that tube on one or both sides, which can have other implications to their health and lead to further testing as to what might be causing that. Also, we do get some blood work. That's a part of it, kind of checking some testosterone and then some of the fertility hormones. Now, a lot of patients will come to me with imaging such as a scrotal ultrasound or will ask about it. It's not really routine to get scrotal imaging, and the reason for that is that most of the things we need to get that I talked about on the physical exam, I can get from a physical exam. Imaging is useful if whether there are questions about what's present on the exam, or if I can't get to a patient. A lot of for posterity health, a lot of what we do is telehealth and reaching offering these services to patients in remote locations. And so for patients where it's just not feasible to get them in for an exam, the ultrasound can serve as a reasonable thing adjunct to that. So again, when you meet with us, we'll talk about some of the changes that we can make to help maximize your chances of conception. We're going to look for causes of infertility with labs in the exam, things that we can treat, and then identify someone fertility treatments are needed either with me, and sometimes we may do the full evaluation, and sometimes we do say, hey, we're not sure we can't find a cause for this, but you need to go to CNET San Diego Fertility Center and talk about doing some of those assisted reproductive treatments that were discussed. Also, as I mentioned, early detection of serious men's health conditions, low testosterone, testicular cancer, things like that we often see. So what can we do? I'll spend a lot of the visit talking about lifestyle changes to make sure guys are optimized in that regard. Sometimes we use medication and sometimes there's surgery. So what are some examples of those things? So in terms of lifestyle changes, avoiding tobacco products, there's very good evidence linking smoking and tobacco to a decline in semen parameters. So making sure guys know that, counseling them on smoking cessation. I will say one of the most rewarding parts of my job is that I work with a patient population who is extremely motivated. And that's very impactful. And I think that guys, when they're on this pursuit of fatherhood, they have this altruistic motivation because they're doing something not just for themselves, but for their partners and for their future children. And so it's really impressive the things I've seen people do in terms of making those changes. I've seen guys quit smoking that have not been able to otherwise. Nicotine pouches is another common one, like the Zyn pouches and other sources of nicotine. That's less severe of an impact as just smoking cigarettes, but still something we recommend people stop. Healthy body weight. There's evidence that men who are very obese or obese and they lose that weight, that's also associated with an increase in reproductive health, semen parameters, and sperm quality. A lot of patients will ask me about diets and supplements. So there's no one magical diet that's been shown to improve fertility. But generally speaking, you want to eat healthy food. Eating processed foods, fast foods all the time is going to contribute to some of those other health problems that we talked about. So generally speaking, I recommend people take a healthy diet and take a multivitamin supplement. Caffeine is another one people ask about. It's okay to have your morning coffee. I tell everybody, if I saw a doctor who told me I couldn't drink coffee, I wouldn't go back and see that doctor. And I get that. So you can have your morning coffee. You just don't want to be the guy who drinks a full pot of coffee per day. I also want to mention energy drinks are a no for me. I've seen guys that have problems with fertility from the energy drinks that they're consuming. So I tell people stay away from those. The natural sources, like a cup of coffee in the morning, or you like tea, those things are fine. Stay away from the excessive amounts and stay away from the energy drinks. Alcohol. So alcohol, there have been good studies on this as well. The best amount of alcohol is zero, but if you want to have a glass of wine or beer with dinner, that's fine. We tell people keep it to one per day. For many people who drink to excess on weekends, it's just easier to cut it out completely, and I encourage them to do that. Substances is also another one. Cannabis products are linked to decline in semen quality and sperm quality. So I always recommend guys, whether they be edibles that they take them to sleep at night, those things, speaking as a fertility doctor, you really want to try to stay away from. Also, talking about the blood work. So hormone therapy. I mentioned the testosterone, which I'll talk about in just a minute, but we do find low testosterone in a lot of guys dealing with infertility, and there are ways to improve that, which I'll mention in just a moment. Erectile dysfunction support. It's very common for guys who are going through fertility treatments to mention that they're having difficulty maintaining their erections. The reason for that is that intercourse and sex goes from a recreational activity, we'll say, to a job that needs to be performed. And so the guys oftentimes have stress and anxiety surrounding that. And the human body's reaction to stress or anxiety is actually to make erections worse. So it's this very cruel trick that nature plays on guys where when you're undergoing a period of stress, which happens when you don't have the erection that you want, your body's response is to make that erection even worse. And so there's cheap, readily available medications that we can use and give to patients that are safe for fertility. And I really encourage you guys to take those if they're having problems. And then, of course, sometimes there are procedures that we need to do. Those varicoceles I talked about with the physical exam, those dilated veins that can impair sperm quality. There's an outpatient surgery that takes 1 to 2 hours. It's a relatively easy recovery. I would say it's an easy recovery that we can do to help improve guys' fertility. And the sooner they get in to see us, the sooner we can get that scheduled and help make that impact. Oftentimes, we actually will, for guys who are born with obstructions or for men who've had vasectomies, we can do sperm retrievals or potentially reverse vasectomy, depending on a myriad of factors I won't get into here. I will say no guy is ever excited to hear me do that. I'm recommending a surgery on their testicles, but the recovery is easy. The vast majority of my patients after their procedure say, "Oh, this is way easier than I thought it was going to be." So nothing to be scared of. I just wanted to touch on the low testosterone thing because this is very popular in the news, and I know there's a lot of marketing. I'm in the demographic for guys who are targeted for low testosterone. And there are studies that's showing that about half of guys who come for a fertility evaluation, we're going to find may have low testosterone that's associated with it. It's very important that these men don't get put on testosterone. That is very important. That's the kind of the last point I want to make here. So this is kind of a very oversimplified diagram of how the brain interacts with the testes. So the brain sends the signals LH and FSH down to the testes. Though the testicles in response to that make testosterone and they make sperm. And so that's measuring those things as part of the evaluation I was talking about earlier. When you take testosterone from an outside source, the brain does not know where that's coming from. And so in response to that, the brain actually shuts off the signals it's sending down to the testes. And so actually guys stop making sperm. So I tell guys, taking testosterone from an outside source is like taking the switch for your sperm production, turning it off. The longer that switch is off, the harder it is for it to come back on. And in some cases, it can't. That's not common, but it is a possibility. Now, there are other medications that we can use to help the body increase stimulation to the testicles to raise testosterone and promote more sperm production. But that's something I won't get into the nitty-gritty details of that, but there are ways to raise testosterone and help sperm production without just giving somebody testosterone. So I'll kind of end there. I know there was some there's some questions that had been shared beforehand. We can kind of answer those and or if any other ones pop up.
Perfect. Thanks, Dr. Rose. That was a great discussion. Yes, we do have some pre-submitted questions, and then I think that'll give time for the participants to think of some questions too, and we can go through those. So I'll read you one of them. So one of the questions is it true that riding a bicycle can interfere with my fertility? This was for men.
Good question. As one of my attending physicians told me in my residency, if that was the case, then in countries where they ride bicycles every day, there would be no children. So, and we know that's not the case. So I tell guys, if riding a bicycle is your form of exercise, I am perfectly fine with that. And I would so much rather somebody be active in exercising and taking care of their overall health than avoiding whatever incredibly rare case it might be where the riding a bicycle is bad for them. If you're training for the Tour de France and you're riding a bicycle for many hours a day, every single day of the week, sure, overloading anything like that can be bad. But if you want to ride the Peloton, go for it. I encourage you to do that. I think the benefits you get from your exercise are going to outweigh any risks.
Perfect. And then another question that came for the men is, can men with low sperm count still get pregnant naturally?
That's a great question. And the answer, as with many things in medicine, is it depends. So we know that there is a correlation between that total motile sperm count for guys, assuming a normal female partner. We know that there's a correlation between the total number of moving sperm in the specimen relative to the chances of conceiving on a given month. And so even if your counts are lower than what's considered normal, it's certainly still possible for you to conceive. The extent to which that's possible is going to depend specifically on where you kind of fall within that range. Guys who have 1,000 or 500 sperm overall in their sample, realistically, that's never going to happen. You'll try your whole life, and maybe some miracle you might get lucky, but it's not going to happen. If you have if we're looking for if a normal semen analysis has 300 million motile sperm, but you have 10 million, yeah, it's possible. It's just you're probably going to try for a long time. So the answer is it kind of depends where you fall out in that range. And actually, the people who are low but still have a chance, that's actually where we can oftentimes make an impact to get them higher to increase their chances every month.
Perfect. That's great. And then this one applies to both of us, so I can answer first, and then I'll have you we weigh in as well. So the question is, can past STIs interfere with my fertility? So from the female perspective, yes, we are particularly concerned about untreated gonorrhea and chlamydia because long term that can have negative effects on the fallopian tubes. It can cause scarring of the fallopian tubes, and it can be scarring to the point where the fallopian tube itself becomes extremely dilated and unpatent. And so that we call a hydrosalpinx. The big concern there is one, that tube really isn't functional, especially if it's something where we don't see any fluid when we do the HSG coming out through the tube. And so that tube is essentially rendered non-functional. The other concern that can happen is that even if the tube isn't dilated, there still can be some internal damage to the tube, like scarring. And that can make it harder for pregnancy to implant in the normal place. So normally the embryo is supposed to be in the uterus. Sometimes we can see situations where that pregnancy ends up in the fallopian tube. And so it is important as we're going through the history when we're seeing patients to talk about past infections or past surgeries, even in the pelvis. And then on top of that, undergoing that fallopian tube assessment so that then we can better assess one, are you at risk of an ectopic and how are we going to manage that? Or two, do we see a dilated tube and how are we going to treat that to still make sure that you have a good chance of pregnancy?
And I would say on the male side, it's very, very similar. So the ones I always specifically ask about are any history of gonorrhea or chlamydia. The ducts that transport the sperm from the testes to the ejaculate are really, really tiny. And guys who've had a history of untreated or recurrent episodes of those infections, you get this inflammation within the transport ducts, and it can lead to blockages where guys can no longer transport sperm. The sperm can't get out. So basically, and they've had a vasectomy in essence. So yeah, it is very relevant. The other thing it can do is if you've had infections of the testicles themselves, sometimes the actual testicles can actually have a decline in function overall because the inflammation and scarring that occurs within the testicle itself can lead to a decline in the number and quality of the sperm. So it is a relevant piece of history.
Great, thank you. And then one of the questions from the female perspective is if I possibly have endometriosis, would there be any type of treatment before my embryo transfer? So endometriosis is actually one of my areas of specialty, so I'm gonna probably talk a little bit beyond the question, which I don't think anyone will mind. But to answer the question for the embryo transfer, yes. So endometriosis is truly a chronic systemic disease with multifactorial effects throughout the body. Essentially, it causes a lot of inflammation in the pelvis, and that inflammation affects a lot of the reproductive tract, in addition to having effects on the brain and metabolism, and even pain perception. But from the perspective of fertility, endometriosis can affect the transport of the egg through the fallopian tube, can affect the transport of the sperm through the uterus to the fallopian tube, and can make it harder for the uterus to undergo all the changes it needs to undergo for proper implantation. So if we know that you have a history, and that's why the menstrual history is so important in our evaluation, if we know that you have a history or suspect that you have a history of endometriosis, then before planning an embryo transfer, typically we recommend medically suppressing the endometriosis endometriosis for a few months. What that does, that essentially knocks out the inflammation and also makes the uterus essentially more receptive to the natural hormones of estrogen and progesterone, which are important for implantation. Or when we're planning an embryo transfer, we usually give the estrogen and the progesterone for proper implantation. And so that medication can either be something called leuprolide acetate or elagolix, or Orlis as the generic name. They both essentially work to lower estrogen levels. Endometriosis loves estrogen to grow, and normally progesterone is supposed to counteract that growth. But when that doesn't work, we can really focus on specifically targeting estrogen production. And by lowering it, we essentially knock out all of that inflammation. And it's again for about 2 to 3 months of treatment. That so far in some small studies has been shown to increase clinical pregnancy rates. I'm actually part of a clinical trial through some of the work that I've done at Yale. And so we're actively looking now at not just clinical pregnancy rates improving, but also live birth rates, and also seeing if we can lower the likelihood of some of the pregnancy related complications that happen for patients with endometriosis. The other thing I wanted to highlight, even before getting to the embryo transfer, is IVF is really an amazing treatment option for patients with endometriosis, particularly those with more advanced stage disease, because IVF really targets all of the things that endometriosis is normally negatively affecting from a fertility perspective. So with IVF, we can stimulate the ovaries, we take the eggs out of that inflammatory environment, we directly inseminate the eggs with the sperm, and so we bypass the sperm having to travel through the fallopian tubes, and then we can create embryos and again suppress the endometriosis before we plan an embryo transfer. But that being said, in patients who are younger or patients who have early stage disease, that's really where the oral medications and the insemination play a large role too, because one, with the oral medication, we're getting more eggs to ultimately be released. And then two, with the insemination procedure, we bring the sperm closer to the egg. And so hopefully that'll facilitate that transport through the fallopian tube. So that was a really good question. I'll see if there are any more in the chat. Give me one sec. Okay. So another question actually that came through the chat is, can persistent HPV affect female fertility? So thankfully, no. When we think about, so HPV, although an infection, is not like gonorrhea and chlamydia, where we're seeing that it's having a large effect on the fallopian tubes. While we do recommend having treatment, just because we know HPV, the concern is that if it's not cleared, the concern is risk of cervical cancer, cervical dysplasia, so abnormal cells in the cervix. So we definitely recommend having that evaluated and treated, but it shouldn't actually have an effect on your fertility. I don't know, Dr. Brems, from the male perspective, because I know the vaccine they offer for men now too, if
Yeah,
seen anything.
it would be an exceedingly rare scenario. I mean, I can conjure some in my head, but not.
Yeah.
I would say no.
Okay, got it. Um, And then another question, Dr. Brems, for you is more looking at, is there ever a situation, well, is there a certain sperm count that you would normally recommend, even if you got 9 million sperm with an IUI, that IUI wouldn't be the best route and really IVF is a better treatment option?
Um, Potentially. So for people who've had recurrent things like recurrent pregnancy loss, there's a specialized test we'll sometimes get called sperm DNA fragmentation, which is kind of a marker of the DNA integrity of the sperm. So for patients who've had recurrent pregnancy loss, or they failed IUI, or we can't really seem to find out what's going on with their sperm, and we try different things, or even just they don't want to get the test, we can order that. And if that number is elevated, sometimes that can suggest that maybe IVF is going to be a better treatment than something like IUI. And there's there's a couple of things you can do to try to improve it. One of the ways to get around it is actually doing one of those minor procedures I talked about, where you actually get sperm from the testicle, because studies have shown that sperm that are within the testicle, they're a little bit less mature and they have not been exposed to whatever environmental factors are impacting the sperm as they make their way through the rest of the reproductive tract. So by going to the testicle and getting those sperm, it can help with IVF. So I would say there are some scenarios, and some of that DNA fragmentation testing can help us identify those patients.
Great, perfect. Thank you. And then another question was about PCOS and what PCOS is and how that can affect fertility. So PCOS stands for polycystic ovarian syndrome. It's essentially a condition where there are lots of eggs in the ovaries, but the ovaries are never getting the signal from the brain to say that one egg should grow that month and ultimately be ovulated. So it's an interesting situation because, again, these women tend to have lots of eggs. It's just a matter of getting those eggs to ultimately grow and ovulate. And so that's where the oral medication really comes into play. And the one in particular, so we have two main oral medications that we use, clomiphene citrate or Clomid, or letrozole. Femara is the generic name. There's a really nice study actually in the New England Journal that showed that for patients with PCOS, the better treatment, not just for getting an egg to grow and ultimately ovulate, but also having a higher likelihood of pregnancy, is actually letrozole. And so that's a situation where I know we talked a little bit about usually if we're going to do an oral medication, we're also doing IUI. For patients with PCOS, usually the bigger issue is lack of regular ovulation. And so letrozole in conjunction with timed intercourse can be used, unless, of course, when that male partner gets a semen analysis, we see that the sperm count is particularly low, if the motility is low, and then that's a situation where we'd recommend adding an intrauterine insemination as well. Okay, I'll see if we have any other questions. Oh, it looks like we answered everything. So I just wanted to say thank you again so much, Dr. Brems, for being here with us and for working with all of our patients. It's really such a huge and exciting thing to have available for patients, especially in the setting of Men's Health Month. And thank you to all of our participants. We'll ultimately have this on our YouTube channel so that patients can watch this again. And then, Dr. Brems, I didn't know if you had any closing remarks that you wanted to mention as well.
No, thanks very much for having me. I really enjoyed this, and hoping we can help some people that were here.
Yeah, exactly. All right. Well, I hope everyone has a good evening.